Okay, welcome everybody to this SIG workshop about health systems design, which is entitled People, Information and Technology as a part of the Design 2022 conference. My name is Maaike Kleinsmann and I'm chairing this workshop today. Before we move to today's agenda, I'd like to explain a little bit more about this SIG, its aims and activities, which you can already see a little bit on the slide. The Health System Design Special Interest Group has been formed around 5 years ago. The seed was planted during ISET 17. I just understood from Professor Clarkson and Professor Maier, who are my co-directors of this SIG. And we have the collaborative goal to create a space and a kind of network for community building for researchers in the design community that are interested in healthcare-related design. We saw a steadily increasing interest in this topic within the design society. But I think what we all aim and what we also would like to emphasize is that we are not only design researchers in this group, we are a transdisciplinary group with a lot of people from different disciplines like population health, but also clinicians, biologists, a lot of different types of people with the common interest about health systems design. And I think this is also what we would like to emphasize, because we can't change health systems as design engineers alone. We all have to collaborate together. And I think what this SIG brings is that we kind of integrate and bring together design research, other types of research, and the practice of health system design. And we think that, we all have a lot in common, and we really want to actively tackle the issues around health and health systems that we face in society, such as, for example, the increasing patient populations and the shortage of staff. And how can we make use of different technologies to really improve this system? Now, we are very happy that the Design Society also saw this opportunity, and that they offer us a podium to bring this all together, because health system design really needs to connect people and technology, connecting research and practice. And we really need to get aligned to make the change that is really needed happening. And in the SIG, we organize events, digital events like these. But pre-COVID period, we also came together a couple of times, and we have really plans in the near future to come together again in a physical space and to really work together. We are working on a collaborative book. We are working on a special issue around health systems. We are really eager to let the community grow and to have you as participants in our community and work on this great topic all together. This brings me nicely to the program of today. After this short introduction, which is now currently going on, Valeria Panuncio will take over from me. She will explain you a little bit more in detail about updates of the special interest group, and then she will continue with a short demo of the Miro platform that we will use today to help us to support our creative ideas and work around the two different topics, which is first a presentation about health systems design, exploring perspective, led by Dr. Alex Comanci and Professor John Clarkson. Then we will move to a break, and after that we will continue this activity on the Miro board, and we will have lively discussions together. Then we will move to Valeria Panuncio together with me. We also have Valeria basically has a presentation about health systems design, people, information, and technology. After her presentation, we will move to another creative activity altogether, where we will have open discussions around the topics that Valeria presented. And then last but not least, Professor Anja Maier will conclude the session with some afterthoughts and conclusions about what we reached today. I wish you a lot of fun and good information and knowledge sharing all together. And I would love to give the floor to Valeria to provide updates about the SIG.
Thank you very much, Maaike. Indeed, I would like to continue your introduction about the special interest group by giving some updates about the latest activities. First, I will just make a difference, which is useful for indeed expanding of what you have just said, which is that there is such a thing as the Health Systems Design Special Interest Group as part of the Design Society, and also the Healthcare System Design Research Group, which are vastly overlapping but are not exactly the same thing. And one important difference, of course, is that the Health Systems Design Special Interest Group is completely contained within the Design Society. It's one of the special interest group of the Design Society, while the Healthcare System Design Research Group is also supposed to be an interface, as you said, with other disciplines, so clinical disciplines, operational research, and much beyond the realms of design. So today we are here indeed as the special interest group, but this is the overall context also that the special interest group is part of. The goal of the special interest group, as you have already introduced, is to create a space to have a community that is interested in healthcare system design. And we would like to, of course, do research to tackle important questions, but also to create partnerships with groups that work on similar topics. Here I start the history from 2018, but indeed we were just discussing that already in 2017 there had been initial meetings about the HSDR. We have had indeed international meetings of HSDR for 3 years up until the official launch of the special interest group in 2020. We had already another meeting, unfortunately, online in Delft, and there's a fifth one coming soon. We don't have a date for sure yet, but please stay updated and join us there to discover when it will be. I will give contact details at the end of this presentation that you know where to look if you would like to stay up to date with the special interest group. Recently, I have some good news about what has been happening within the SIG. We signed this contract with Springer to be able to publish a major reference work on health system design, and also started inviting chapter contributors for the same. Last year, we have also organized a workshop at ICE 2021 with AstraZeneca. There was a very interesting brief that we worked on preventing hospitalization by self-monitoring, and we did a hackathon on this challenge. We also had some recent publication in the book in the SIG, and in general also I can later share this in the chat. But we also have this open knowledge map that brings together a lot of relevant publications for this topic. So if you would like to know more about and have some literature to look into what we are doing, this could be a good place to start. We also have ambitions, of course. So we are looking ahead, and while we have seen that many of the things that we wanted to do in 2021 have been happening, some of the things that we want to happen in 2022, such as the special issue in health systems, are happening. There are still many things that we would like to do in the future. We would like to keep on expanding the SIG, to keep on growing and attract more researchers that are interested in these topics. We would like, for instance, to also start in the future something like a summer school of the special interest group, so that we can also have more and more, especially young researchers that are interested in this topic. We also have an upcoming special issue on health systems, is the name of the journal. The special issue is on using participatory systems approaches to improve healthcare delivery. Submissions are now closed and papers are being reviewed, but what I'm happy to say is that also there are 3 papers that already have been published as part of this special issue. And here is the list, but there are many more coming. And so keep an eye on the journal if you would like to be updated about that. Now I would like, especially if Maria helps me, to just try a little bit to see if we can all access the Maier board before we have the latest activities in Maier. So if Maria could just share the link of the Maier board, and we could all see whether we can at least get in. That would be a start, and then I will proceed to try out some basic actions to see if we can all work with that. I'll now quickly stop. Thank you, Maria.
Yeah,
see
so,
that you have
share the link. It's in the chat. You'll find it in the chat.
And I would even like, this is the interactive part starting. If you would please, as participants, tell me if there is any issue accessing the board or whether you can access it all right. I'll also migrate to the board to see who gets in. Very nice. I already see a lot of arrows in the board. Very good. Perfect. If there is also, if later in the workshop there is going to be anybody who has difficulties accessing the Miro board, feel also free to write me in private, in a private chat to see what I can do. Otherwise, what I would like to do, and here I will stop sharing my presentation and I will start sharing the Miro board itself. I would like everyone to just start. The main thing that we will do today is writing on post-its. So if we could all just copy paste an existing post-it literally by clicking on it and copy pasting it like with Control C and Control V, or if you're using a Mac, a different combination, and to write on it. This is the main things that we will need to do in Miro for the duration of the workshop today. So even just being able to do that should get us going. Perfect. I see a lot of you already doing it. Perfect. Thank you very much. Nobody having issues, please feel free to also jump in and either write in the chat or tell me if anything is going wrong. Otherwise, I see quite some success already in the Miro board. So perhaps we could continue with this. We won't use the Miro board right away. First, we will have a presentation, but we first wanted to troubleshoot in case there would be any issues. But it seems like it's going well. What do you think, Alex? Is it good enough that we could move on to the next part?
I think so. I think people seem very competent in Miro. Yeah. So, yeah,
nice.
Could carry on.
But please, for everyone, even from now till when we will use it, also feel free to write me directly in the chat. I will try my best to help.
Even though I think we have more people here than on Miro, there are 13 of us here, but there are about 7 in Miro. But I guess maybe not everybody wants to be on Miro, which is fine.
Join is a fun activity. I see Kamia has written to me that she couldn't find the link, and I have now sent it to him or her. If there is anybody else that has the same issue, also please let me know. Otherwise, in the meanwhile, I will leave the stage to Alex for the first presentation.
Thank you, Valeria. I will share my screen. Share screen. Oops, sorry. Get this up first. This one. Share screen. Which one am I sharing? This one. Wrong screen. Why is it not sharing my screen? Let's try again. Share screen. Window. All right, got it. We got it. Can you see my screen? Aha. So let's go to view. The screen.
By the way, maybe in the meanwhile, if it's of any help with anybody, at first I was seeing this the presentation as just as small as all of the other people, but then I can put it full screen so that I can see it better. I don't know if anybody else had the same issue.
I hope everybody can see the presentation. So what we want to do in the next few minutes or so, maybe 15 minutes, is to explore this topic, health system design, exploring perspectives. And I think that word exploring is carefully selected. It means that there are no answers here, but more questions for discussion later, for really to start a conversation. So what we want to look at is if I can just get this thing moving. Okay. Yeah, so here's the aim of what you're trying to see, to explore three aspects of health from multinational perspective. And we want to look at England as a starting point. And the three things you want to look at is the scope of health to start with. What does health include? And the second one is the state, or you might say the measure. So how much health is health? And the third thing is the system. And that's about what is included in a health system in terms of the boundaries of what we might consider as a health system. And then we would, as I said, say a few things about the system in England as a starting point for conversation. Why are we touching on this topic at all? And I think part of what you heard earlier on is that we don't just form a group within a design society, but we really intend or hope to actively engage with the health community and other communities that have interest in improving health. So this is part of this is to facilitate better engagement in the health and care community, and also to start a conversation. So this is not meant to be a final or provision of answers, as I said, but just to begin a conversation of how engineers or designers understand health, and how do we operationalize the concept of health system design in our attempt to improve health. So talking about health systems, of course, context of design has various aspects to it. And I picked up on a few examples of how health systems have been compared in the literature in the past. And this is an example from the World Health Organization. The World Health Report 2000 was all about health systems, but that was one of the main moves towards a focus on health systems in global health initiatives. And so the focus there was very much on outcomes and performance, so comparing various health systems in terms of how they perform or what outcomes they are able to achieve. Another example is from Vent 2014, also comparing health systems mainly from the OECD organizations and looking at financing models and provision of care and how care is regulated. And more recently, there's another example from Professor Thoth in Bologna, also looking at comparison between health systems, but then taking the areas of integration. So how do you integrate insurers and providers, integrating primary and secondary care, How does the gatekeeping work? How much freedom do patients have in such systems? So comparing a range of different health systems from those angles. And these are just 3 examples really to say how we health systems are compared. But the question really for this session is that as engineers, when we think about health systems, what do we mean? And how do we design what we think a health system is? So to go on exploring this further, we mentioned the scope of health, what is included. And very often the literature portrays these 3 key elements of what is called health: mental, physical, and social well-being, at least from the WHO perspective. And this again leads to the state of health, or how much health is health. So from the WHO definition of health, it has to be a complete state. It has to be full. Physical, mental, and social well-being has to be complete, which has led to a lot of critiques of that kind of approach. And others have questioned whether it has to be full to be health, or does it have to be sufficient, and what does that actually mean? So these are some of the realities in terms of wrestling with the idea or the concept of health, and which we want to just put across. And we have explored this much further in our paper in the conference, which will be presented tomorrow. And so you can, if you want to look into this more further, you can please pick up this paper, or you can get in touch with myself or John. We'll be very happy to chat about this. But for now, we want to just explore a bit further in terms of the aspect of health as a system of systems, and looking at the boundaries of health. So in reality, you would agree with me that health involves everything from the individual's health action to population interventions to improve the health of a whole nation, and also from new products coming into the system, all the way to medical waste management, which is a whole system in itself, and also from the consulting room as a system, and again, all the way to national specialist networks, which are on a much bigger scale. And you could think about a very small process, which could be a nurse using a syringe to inject a patient. That's a very process within the health system, to the other extreme of a national supply chain. And so this is just painting a picture of this extent of health and the boundaries that are possible within the conception of what a health system is. So in England, this is one representation of the health system. In fact, this is old now. It has changed. This was from 2017, where you have the Department of Health, and emphasizing how money actually flows down, and how the various delivery systems and support and oversight work. So the green boxes you see are the national bodies, while the purple ones are the local bodies involved in the care delivery. And here is another picture of that by the King's Fund in London, a more artistic perspective on that. You can see maybe the politicians at the top, where money comes in there and it flows through various pipes into various parts of the system, all the way to the individual person. And down there it says me and you, so we are part of that system. But then the question still remains, what is the system? Is it the whole thing that is the system? Or is it this part of it that is the system? Or is it that part? And I guess from a designer's perspective, you would say all of those are true. The whole thing, a part of it, and even a much smaller part. So the question really that we are throwing up for discussion this afternoon is, how does this perspective on a health system help us fully appreciate the scope of what health includes, the state of its attainment, and the whole system and its boundaries? And more importantly, from a designer's perspective, how do we operationalize the concept of health system to facilitate design? So when we say we want to design health systems, how should we think about that, so that our designing becomes more meaningful and more tangible and clear in the process of doing so. So that brings us to the end of this presentation, and then we'll take a break. But before the break, I think I want to just explain briefly how the activity would work before we go on a break, and then when we come back, we can just go straight into the group. So what we want to do in the activities is really to look at the different perspectives on health systems from different countries. So we all represent different countries in this group right now. So just to bring our different national, if you like, perspectives or our understanding of what's going on in our various countries into this discussion. So we will later then discuss, and when we come back from the activity, what this means for design. So the first thing is to provide a description of the health system of your country on one frame in the mirror board, and I'll show you what that looks like right now soon. And you can draw this yourself if you want to, or copy and paste from the internet, or just write a bullet point description of what you think the system involves, and then write down on your views on the strengths and limitations of that system. So here is what I think is going to happen. So you got a link already, you're already in Miro. So here's an example. You will see that in the Miro where I put my name in England talking about. So if you fancy it, put a flag of your country there, and then write your own name if that's optional. Then provide that description. So as you've seen here, we've got the two examples from the English health system there. And I'll put a few notes there on what are the strengths or weaknesses or advantages or disadvantages of that system. So that is roughly what we will be doing. So I'll go back to the break time, and then we can take that 10-minute break, and then we come back to the activity after our 10-minute break. So Maaike,
yeah, Alex, we are in the comfortable position that we are ahead of our schedule. So I think, what if we just come back 10 past 2 our time, maybe 10 past 1 your time?
Okay, that is fine.
Yeah.
So see you at 10 past 1.
Okay, thanks. See you back.
Thanks, everyone. See you soon.
Hi, everybody. I hope that you all had a good break and that you got yourself something to drink and or to eat. We are now continuing with the first activity on the Miro board. Alex, I think a few people have joined us, so it might be good to just repeat a few of the practicalities and the task before we dive into the content.
Yeah. Thank you, Maaike. So, as I said, this is mainly about your perspective on your country. So, we just want you to describe your system as best as you can. It's not going to be perfect. If you know any picture online, you can copy and paste in the Mirror's frame. That would be great. The great advantage of Mirror is that you can zoom in and make your frame as big as you want it to be. So do zoom in and make it big and put your system or description or whatever you have there. And then the second part is to put your perspective or your views on the strengths and weaknesses of the system that you have described. And you can have not just one description, you can have two descriptions, or if you like, three, but do zoom in to the frame. What I need would be good to know is that if you are maybe more than one, maybe two or three of you or more are from the same country and want to work together, we can put a link, a breakout room in the chat box for you. So just let us know. We can put a breakout room for you so that you can work together on one frame. There is enough frame for everyone. So please, if you need to go to work together, please let us know. Otherwise, we can pick a frame each and work on it. I can see Sweden's Frederick started already with a flag in the frame. That's very good. So thank you. Any questions, just shout out. And we would, we've got about half an hour, so 40 past the hour. I like the names of the participant, the visiting thinker, and the visiting writer, and the visiting builder, visiting researcher.
For the ones that I see in the open list, but not on Maier yet, again, please let me know if there's an issue. For instance, you came late, you're not sure about what's going on, you can also write to me directly.
Thank you, Valeria. Can I also say that if there is a website where you think there's very useful information about your system, do feel free to put a link there as well, so we can follow that up later. So do feel free to add any useful information to your frame as well.
Alex, would you say, for instance, something such as the Minister of Health of each country's description of the healthcare system, this kind of?
Yes.
Okay, perfect.
Yes.
Thanks.
So if there is a link to that would be helpful, especially if there's an English translation of it. Okay.
Yeah, I was seeing, of course, many of the graphs are in the original language of the country. So
yes, yeah, if there's an English translation, I think most websites can translate these days, don't they? So yeah, that'll be useful.
I like that we are having quite a few countries also in different continents so far.
Yeah, I think it's really interesting to see the diversity.
I am tempted to go to the Netherlands, to the Dutch one as well, having experienced both healthcare systems in Italy and the Netherlands, I think. And if I'm allowed, I would like to go
Go
and add a
ahead.
few notes. Thanks.
Yeah, there's. I think there's enough. There is enough there.
You can join me, Valeria.
We've got a few more spare frames.
Valeria?
Sorry?
Valeria can join me in the Dutch one.
Thanks.
So do you want a link then? Maria?
Yes, sorry.
Can you please put one breakout room link for
For the
Valeria?
yes, of course. Just a second.
For the Dutch, please.
Yep.
So if you click on the link, that will take you to a breakout room, Maaike and Valeria. So click on that link and you two can go to the same room and discuss.
But please remember to mute your mic in this room so that we do not hear your communication, unless you want us, of course.
Could we have a Danish one as well?
Of course.
Yes, you can.
If Alex, so just so we put similar visuals on. How do we actually see people's names in Hopin? Who is there? Can we see that?
Yes, there is.
Oh, so if you click on session to your right and click on people, you will see the name of people who are in the session.
Possibly.
So do you want a breakout room as
yeah,
well?
Let's do that.
Who would you want to go with?
And
Okay.
And Faith, maybe, or maybe just by chance.
Maria, can
Yes,
you
I
give us
have.
another
In the
breakout
session
room,
chat,
please?
you have a Danish room added as well. If you cannot see it, just please let me know.
Chat. Yes, I can.
Can you
Yes,
see
thank you very much.
The Danish room. Yeah.
Hi, Alex. Alex?
Hi, Maaike, can you hear me?
Now I
Hello.
can hear you. Now I can hear you, but I can still hear Anja.
Oh, what do I do?
Yeah, can I?
I
How
don't
do I?
know. I also know how it works. I think you have to mute your mic here and then go to the other one
Uh-huh.
and then try, but I'm not sure if it works.
Yes, that's correct. So please just, yes, that's exactly what you're supposed to do.
Hey, Valeria. Hey, can you hear? I can't hear you.
Got about 5 minutes more.
I like your flag, Alex.
Yeah, I thought somebody turned my flag into a football.
I thought you were laughing about my complaints for pain management in the Netherlands.
No, I
And
was.
relative disregard for anesthesia.
So many things are possible in a virtual world.
Finish. So anymore.
Dr. Kleinsmann, I have a trouble hearing you. Do others hear you well?
I can hear you.
You can also hear.
I think I have. I can, Maier. I have today with my back functions, so my role is I'm suffering from it.
Oh, it might be me then. Just okay.
Should we get ready to come together then?
I think that's a good idea. To you, Anja. I have severe problems, so I will.
Are we all back? Maria?
Yes.
Do you have everybody back?
We do not have Dr. Kleinsmann, as far as I can see.
We've lost the chair.
No, she's rebooting the laptop
Okay.
because it really seemed like the audio was better.
Okay.
Alex, I wonder if we should just work along the sheet.
Okay.
Country at a time and just see what jumps out of the page.
Okay.
Do you want to share your screen so we can see a part of the mirror at a
I
time?
will share my screen. I think it's turned out actually much better than I thought.
I had every faith that the people on this workshop would do us proud of it.
Yeah. Share screen. Wait a second.
You're looking positive.
Right, can you see my screen?
Not yet, no. Oh, just coming up. Do you want to zoom into the first page there, Alex?
Okay. So the first one we started with was England. And if I go back to that, so that's what I claimed to be the two maps, which I think, like I said, whilst we're working, I just thought I would just put a comment on that, highlighting the idea that the idea of social care includes quite more than just the personal care, that there's elements of practical help that is included in that. And that is because there are various implications. So before somebody leaves home, so leaves hospital and is discharged into home, they have to look at what their setting at home is like. So not just the social care provision, but can they do all the practical stuff? Otherwise, they will stay in hospital. So it's quite an important element. So I think one of the strengths I find with the English system here is that it has a very full coverage of health, that the mental, physical, and social well-being is a key part of that. And also, I think it's also being free at the point of care is an important element of that. And the strong emphasis on healthcare, I think that can be both strength and limitation. And also any element is at worst. Okay, I didn't
That's
see
because I
that.
wrote it out.
Okay. Do you want to say a bit about
so
that?
when you look at any small part of the English system, it's complicated. You stare at it long enough, you can tend to understand it. I put the counter to that lower down on the limitations. When you look at the whole, it becomes complex. Patients and public can take many different routes through the system. And that's a challenge.
Yeah.
And I also said that local ownership of the key elements leads to a lack of integration. So different parts of the England system are pulling in different directions. They have different challenges in how they should perform. I don't know whether that's something we'll see in other countries further down the line, but that was a thought about what's distinctive about the NHS. It is free at the point of care, but it's not perfect in what it can deliver.
Yeah. Do you want to say something about how we operationalize the concept of the health systems in this context, John?
I think if you'd ask the people in the NHS what they think of as a systems perspective, they take a very high level view of what the key elements are. Whereas we would say there are systems within systems within systems. So I think when we talk about systems locally in England, there's a great danger of misunderstanding of what we're talking about. Shall we skip to the next country? And just if people can highlight the things for them that are particularly distinctive or important about their own system, that would be really helpful.
So you go to Netherlands then. Maaike, you want to give us a bit of a explanation?
I believe Maaike might still be trying to reboot her laptop. Perhaps I can fill in with my...
Yes, go on.
I see that she has... It's
yes.
interesting because this is already quite a different description even of the system from the British one that was based on... the English one that was based on parts of the system. Here, she went for a division between levels of care, which of course is a different way to describe.
So what are those levels? Can you explain those levels? I can't read the...
Oh yeah, right. It's let's say the 0 level of care, and then the first line and the second line. The 0 being
specialist
prevention, care. Exactly. The first being primary care, and the second being specialist care. So of course the which connects a little bit to I think what you were talking about regarding social care. So where are the boundaries of the healthcare system? Is it really just like from the GP? A lot of people think of it as really the first level, but you could even extend it if you want and connect it to, let's say, other functions. So that are more about maybe health and well-being and not as what we usually call healthcare.
Okay, health and well-being. So you put an emphasis on well-being as well.
And prevention, and primary prevention.
So it's a bit more like the universal and prevention as well. Okay.
Regarding advantages and disadvantages.
So some of your...
Yeah, I have filled in some filled in. I personally, this is really limited experience, but I thought I quite appreciated the secondary and tertiary level. I think many people instead had quite bad experiences with trying to get through the GP We try to get a diagnosis at some point that it's something that I feel in the Netherlands. It's almost
Okay.
it's also kind of a running joke in the Netherlands that the GPs just give you paracetamol, whatever you have. If you get in with, I don't know, there is this running joke that they're basically
Is it one medication for everything?
paracetamol dispensers. That's GP. This is the stereotype, and I think it's quite, I need to say, like quite accurate. But yeah, this is something that I've heard many people talk about. It's quite a structural issue, if you wish.
Okay.
In a sense,
Okay.
primary care works very well for ensuring that not too many people, crowd the secondary level of care. But then sometimes that's dangerous. Sometimes it's too strict a gate.
Okay.
So maybe, Valeria, you can then tell us about the Italy map, which is the next one.
Yeah, and as I said before, I have had. Yeah, exactly. I've experienced that at least relative to other country, there is, maybe this is cultural, but quite some resistance in providing anesthesia, even for treatments that in other countries wouldn't even be. There wouldn't be a discussion about doing them under anesthesia or not. In the Netherlands, it's always like, are you really sure you want to take it? Which, I mean, I personally find, I think it's an important aspect of patient experience to try to avoid pain as much as possible. And that is kind of, I think, not really appreciated in the Dutch healthcare system. Again, from personal experience, I have no data about this.
Can I say that for those who are watching, please do join in the conversation, because you are allowed to share your video and audio and also take part. So please do feel free to click the button to your top right, the blue button, and it allows you to share your video and audio as well. So Valeria, do you have reflections on the implications for design in terms of how we operationalize the concept of health systems design?
Well, so far I already see an interesting distinction between the way we define the British system and the Dutch one, because of course it's two different ways to define the system, looking at components and looking at levels of care. I guess both useful for different things, and both can be useful for healthcare system design, but in different ways.
So
I even see that later on that are yet different ways to describe the system.
I think what's interesting, Valeria, is that there are different ways of describing. I'm not sure there are different ways of behaving. There might be. We have the same layering in England. It could be the translation between layers that behaves differently in different countries. So in that spirit, if we can move across to Sweden, and as Alex said, if you want a request to be visible and to speak, then who can tell us about the Swedish model?
I guess I can.
Thank you.
Oh.
Yeah, Frederick, yes.
Yeah, I think I can hear myself now.
Frederick?
Yeah?
Frederick, I'm back in, so I can take a little bit of the chairing again, but maybe it's good to introduce yourself very shortly.
Yeah, sure. But I hear myself.
Yeah.
I can hear you.
Is that from your system?
Maybe it works like it. Yeah. Okay, I can do this. Okay, so my name is Fredrik Clarkson, and I'm one of Maaike Kleinsmann's new PhD students. I'm doing a PhD for Maaike for the past 2 months, and my topic is data-enabled shared decision-making. So I'm fairly new in the Netherlands, so therefore I chose the Swedish system. And I worked with pre-hospital care in Sweden for the past year. So my view is mostly from the pre-hospital way of thinking, I guess, in the Swedish healthcare system. But what I wanted to put pressure on in this healthcare system is that in Sweden we have in the north there are very sparsely populated regions, and in the south there are more densely populated regions. They're very different in many ways, and each region also has their own. They can decide on their own on how they want to spend money and in which way they want to innovate. So they're very different, and they don't speak to each other that much in terms of like IT systems. So that's a big issue. But I also put like a positive with this is that it's easy to like compare different systems and how they work. So there's also a way to compare system and see what works best.
Thank you. Do you have any reflections for that in terms of design?
What do you mean in terms of design in this? Like, what do I think should change?
Yeah, so as what we want to, in terms of designing health systems, how we operationalize that concept to facilitate design, because it's often taken to be the national thing. From the way it's structured in Sweden, do you see any
well, yeah, like
advantages in making it easy to operational?
Like the main thing that needs to be done is like how can the different ITs, how can we send information between different, like both different regions, but also like in the region there are multiple municipalities, and how can they talk to each other?
Okay.
Now it's really difficult to do research and to like perform good healthcare, because it's difficult to get a hold of like patients' journals. Like if you're a region, you can't really get a hold of the municipality journal, and that kind of stuff is fairly difficult.
Should we move on?
May I ask just one thing? Frederick, I had the same, basically for the Italian system, I had this kind of conundrum because it's also regionally managed, but that means that it's kind of more tailored to the needs of different areas, but also that it's more inconsistent, and that there is, of course, inequality. There are some areas in which care is very good and some in which care is very bad. So I thought that was an interesting thing because it's the same feature, it's the same systemic feature, but it may have both advantages and disadvantages. I was wondering if maybe Sweden manages to have a tailored, regionally managed system that
I think there's
doesn't go that much into this issue.
Yeah, I think there's an advantage as well.
For instance, apart from urban and rural, in Italy there is a very big north-south divide. I don't know if there's any such thing in Sweden.
Well, the rural and dense areas are kind of divided into the north and south, so so that's quite similar. But also, it's more populated towards the water.
So if we can skip to Tina now for Germany, we're getting a bit short on time. So if we can just tell us the key things that are maybe distinctive or different. So Tina.
Sure, I hope everyone can hear me. So when I think about the German health system, I guess the main challenge, or what is maybe different to other countries, maybe that we have different forms of insurance you can have. So in Germany, you're kind of always have the statutory insurance, but if you kind of have more money than others, then you can also have a private insurance, and then so you always get a basic treatment, and this basic treatment is of course not that bad. So we are from a technological point of view, we have innovative treatments, but if you have a private insurance, it's just some kind of the better treatment you get, and sometimes it's kind of over treatment, because it's like the doctors can just make more money while treating you. So this is maybe the main problem in the German health system. But instead of this, I guess the German system is, so I like it. It's not the best, of course, but it's free for nearly everybody. It's available for everyone. We have a free choice of doctors. The rescue services are well integrated, which I really like. And as Corona showed us, that we kind of have a very robust system when it comes to such huge crises. And yeah, of course, what I really don't like in the German system is that we we are not really that good into e-health. So I guess there would be much more possibilities, but we have such a complex system, and the bureaucracy is just very high in Germany, everywhere, as well as in the health system. So this is kind of a challenge to really make those applications.
Great.
Yeah.
Thank you, Tina. So next, Croatia. Maria.
I'm definitely not the best person to talk about this because I know very little about health system, but in Croatia. But as far as I understood the German system, it's very much alike. So we share same limitations and strengths. We do have some e-health applications which started working better during the corona crisis. So everything is integrated and you can have access to all of your receipts and diagnoses by any doctor you ever visited. And that's all right and that's okay. But I don't know, I think it's in a way fair system, though it has a lot of limitations and it's very slow. You have to wait. We have really a deficiency of doctors, so you're waiting for a very long time for everything. But other than that, I think it works kind of nicely. One thing that is more of a fun fact than anything else, so we are actually one of the best countries regarding transplantations because we have organ transplants, because we have the thing where everybody is an organ donor unless you explicitly state otherwise. So we're actually good at that, and that's basically the best thing I can say about our health system. Otherwise we have a lot of problems, but the system wise I think it's quite like the German one.
That's great. Thank you, Maria. And I'll just swiftly going down the line. South Korea, Jiwon.
Okay. Hi. I'm also working in Maaike and Valerie and Frederick. And soon I'm moving to Hospital of Netherlands as a design researcher. So I'm also very interested in this group. And particularly for this topic in Korea, the interesting thing is we don't have any private sector involved in, and we use patient as a co-payer. So I think around 80% is paid by government and 20% are still paid by patients, so ourselves. And we still need to pay the government, and that payment is different by your income. So everyone pays differently to government, but that 20% still you need to pay to hospital is always same for everyone. Sometimes it's covered by government if you are really low in economic low income. And also special thing is in Korea all the hospitals are with the specialists, so we don't have GP, but specialists they can have their private hospital, but we can easily go there. So strength is we don't have any private company involved in, so cost is always regulated by government, and that's why hospital always need to do their research and tell to the government that what they are performing is needs high price to get back from the government. And also we have easy access to specialists. And however, since it's really relevant to how many people you are curing, the many hospitals are located in city where many people can come and they get much money back. And also prevention part is not covered by government, so cancer screening or like preventative checkups are not prevented, so not covered by government. So it's very self-driven. It's cheap because you only pay 20%, but still you need to initiate to go to see doctors. So in the end, many people just go to hospital and get MRI very cheap price, and then that makes the high burden of the doctors. And then their pay is high, but still not high compared to the working hour they are having. That's a limitation.
That's brilliant. Thank you very much. And Denmark next. Anja, Alex, tell us something we don't know already quickly, please.
Yeah, I guess Anja can jump in at any time if she'd like, but I will try and quickly go over it. The healthcare is organized mostly regionally. So it sort of goes down from the national level to the regional level with the 5 regions. And then there are some parts of more home-based care for vulnerable groups down at the local level with municipalities. And basically, the main point of contact is with your general practitioner, which would then send you further to a specialist or to the hospital system, which is all free, free access to all citizens and paid for by taxes. And it is extremely digitized, so it's defined by being extremely digital. We have our yellow health cards that we use for access. They're also our social security cards. They've also been recently moved on to an app. We can also access all of our health data through the Sunhill, the health.dk website, which is also an app as well. So that included sort of COVID test results through the pandemic. So we have a very high ability to access all of our health information and our health data. It also syncs with the health data that's in the actual healthcare system at the hospitals. So all the data that your doctor puts in on your case file, if you visit the hospital, for example, that's also a sort of interfacing section of the healthcare app that you can actually access. So you can also see your healthcare records in that way. Some of the strengths are that there is a large investment in things like super hospitals and in new technologies. It's very well connected to the biobank, so the sort of national health database. So it means that as long as you get the right approvals for research, that you have access to a huge amount of health data for citizens over a really long period of time and in different parts of the country. With that being said, some of the limitations are that within the sort of daily practice of care in separate departments, they can still be quite siloed, and it is sometimes difficult to get collaboration between different healthcare areas and parts of the healthcare system. Another limitation is that there is a lot of new technology being implemented into healthcare here, but there is also sometimes a lot of pushback with the lack of training and sort of user-based co-design that comes with the integration of this new technology. For example, the American company Epic had they run this healthcare platform, the digital healthcare platform for the central region of Denmark, so the Copenhagen region. And when that was first implemented, and still now, you can see a lot of the sort of glitches that came from moving things over from the American system into the Danish system, sometimes just with language and translation, but also with the differences from a public to a private healthcare system and what that's meant for the interface and the usability when moving between nurses and doctors in the system.
Thank you very much.
Maaike, I wonder whether Maaike wants to let us keep going, or
yeah, I was wondering how many countries we still have left.
We've got 3.
Yeah, the problem is that I can't get into the Maier and at the same time into this platform, so you have to help me a bit here. Yeah, let's go for 3, and then Valeria has to speak a bit faster.
So, just one.
No worries about that. I can cut it a bit short.
One quick visit back to England. I've just put this one together because we have a new integrated care partnership starting on the 1st of July. It has the advantage it's a new integrated care system, and it has the disadvantage it's a new integrated care system, and nobody knows what it is. And I put that in just to highlight that we're sort of trying to go more regional from being national, but this is a typical reorganization that happens every 3, 4, 5 years. And I don't know whether that's the same in other countries, but in England and the UK, we're forever having to adjust to something completely different. And all the organization is different, and somehow we have to carry on. So that's why I put that one in there, just to take a different perspective on what's going on. So India was the next one. Have we got somebody from India can tell us briefly what's special?
Anish?
I am afraid Manish was trying to
Manish with us?
join audio and video, but
very good.
Thanks a lot.
Can you tell us very quickly what's distinctive about your system?
Yeah, I think the distinctive thing in India is the diversity which is there. We have both public and private systems. Can you hear me okay? And of course, there is a lot of diversity because of both economic levels of economic prosperity available with people, as well as disparity between the Indian public system as well as private system. So that's one of the distinguishing features. The other thing is
your audio is not very clear. Is it just me?
No, I also cannot
I
hear.
was
But
wondering the
previously,
same.
Can you hear me now?
Yeah.
I'll try and come. Okay.
Yeah, you have to come close to the computer, I think.
Right. Let me try again. So I was saying the most important feature I think in Indian Indian healthcare system is the diversity which is there. Of course, it doesn't serve everyone very well. There is a lot of divide between the urban and rural, and also people who are well off versus people who don't have that much of economic capabilities. And that creates a lot of challenges, and a lot of Indian population is still paying out of pocket. A very small fraction is paying through insurance, and that makes a lot of difference in terms of how healthcare services are accessed, and at the point of care as well, that makes a big difference. So I'll limit it to these things, but there are other points which I've mentioned on the slide as well.
That's really helpful. Thank you very much indeed. So if we then just go on to, what have we got next? Singapore.
Hi, hello everyone. Am I audible?
Yep, we can hear you. Thank you.
Yeah. So in Singapore, majorly the healthcare systems are well connected with the government and the Ministry of Health, and there are different categories of the healthcare system, such as the public, private, and which fall under primary care and the hospital care. Under primary care, there are different sections such as polyclinics, the general practitioners, and the family medicine. And hospital cares, like the advantage is that the hospitals are put across the island, so they are accessible for the residents across the island, and the information is well connected across the island, irrespective of whether it's public or private hospitals that the patients or the people go into. And Singapore healthcare system mostly focuses on preventive care, where there are a lot of campaigns, promotions, and incentives given to the citizens and permanent residents for following preventive cares. And there are a lot of campaigns which happens for health awareness and preventive medicines. And majorly the strength for the citizens and the permanent residents is that they have a coverage financially, partially through the MediSave, which helps them in paying out their medical expenses apart from the insurance, because it's very expensive. And the same does not apply for foreigners. It becomes a bit of challenge when the immigrants do not have insurance coverage for the particular healthcare they are looking for, which ends up that many foreigners travel back to their home country to undergo certain surgeries or major care. And I don't know whether it's normal across many countries, but maternity expenses are completely out of pocket, majorly for foreigners. And in a way, MediSave do help for the citizens and the permanent residents for maternity. There is a subsidy for the subsidies are not same based on their immigration status, so it changes based on the citizens, the PRs, and the foreigners. And there are additional subsidies through the social workers, where they do financial counseling, and the government tries to help for low income level people. And another advantage is that the information is updated and well connected. The care is being updated on and off based on the information processed by the Ministry of Health. Yeah.
Thank you so much. That's really helpful. And last but by no means least, Alex, can you give us a very brief tour of the Ghanaian system? You're very quiet, Alex.
I was muted. Sorry. Can you hear me now?
Yep.
Can you hear me? Okay. So I think the main thing I wanted to highlight is the multiple elements of the health system, which is not what one would think of as a traditional, at least from a Western perspective, that there is the traditionalists that provide a lot of health interventions and also spiritualist interventions, so which is not conventional health care, but have quite a big part of the health provision in Ghana. And you can see the different elements. So you take the National Health Insurance Scheme, which was introduced as a result of reducing out-of-pocket payment for health, but that has a huge problem because it's not sustainable, where only 35% of the population actually contribute to the scheme. So about 65% of people are exempted from it, like children, older people, and also mothers with children. So it's a very interesting principle, structure or system in principle, but in reality, it's not sustainable. So just to highlight the tension between making things better and also how to make it sustainable, at least in developing countries. So that is a quick summary of that.
Alex, thank you very much.
And I think, is that the last
I think
one?
that's it, isn't it? Is there any more?
Yep.
Nope, I think that's it. We better sign off quick before Valeria gets too angry with us.
I think that's all.
Thank you, everybody.
Okay.
That's been a really fascinating tour.
Thank you, John and Alex, for this great first part of the workshop today. I think it's amazing with how little people we are, and how many nationalities we have in the room. So I think that is really nice. And that brings us to the next presentation. I think, Valeria, can you maybe share your screen and start your presentation, and then we will see that we shorten the break a bit to kind of get a bit time back.
Indeed. Can you all see my screen and hear me?
We can hear you and we can see your screen.
Perfect. Perfect. I will go for just a very quick presentation about the people, information, and technology side of health systems design, which is also the name of the workshop. So it's nice that we thought a little bit about what is a healthcare system and confronted different healthcare systems from different countries. But also one thing that it would be good to reflect upon together is these three aspects of people, information, and technology. So I'm going to quickly go through some examples that I think are intriguing about why we think that people are important for the functioning of health systems, why could we say technology is important, and why information is important. We will also then quickly go through a reflection on why is this division even relevant when we talk about healthcare systems design, and how can these three perspectives be integrated. So to go through it, I think also because this is a design community, I will not have many issues in convincing you that people, of course, are very important for the functioning of health systems. But let me also just give an example that I think gives some more nuance to this notion of the centrality of people for health systems. So this is a project that I worked on a few years ago. And the project was a system. Basically, we started from an algorithm for that could predict based on patient data from patients in the intensive care whether they had a high chance to develop acute kidney injury, which is a very common, unfortunately, adverse event that can happen to people who are in intensive care. And that the good news is that it can be reasonably predicted based on the continuous data that is collected from people in intensive care. So we had an algorithm. We started from the technology in a way. And what we then needed to do was to build a service around it, was to decide, which kind of, which staff member would get the notification that a patient was at risk of developing acute kidney injury. How would that notification be delivered? All these sort of things. In the end, we discovered that the main challenge of this project was not the technology, was not the information, but was to integrate this concept of acute kidney injury prediction into this very complicated workflow of intensive care staff. This is why, in the end, we focused a lot on ways to integrate this new function into the workshop. And so we thought a lot about, interfaces that could be customized by people receiving the notification, ways in which they could prioritize certain alerts or enable scheduling or delegating to other care team members. This really became the core goal of the project. And I'm happy to say the system that was developed out of this project was later tried in a clinical trial. And on the left, you can see some of the results. The pale gray is the intervention group, and what the graph means is the proportion of people who increase from stage 1 acute kidney injury to stage 2. So the fact that there are less people in the intervention that do this progression is a good sign. But perhaps even more interesting is the fact that we noticed another positive effect of introducing this system in the intensive care that we had not predicted, which is the fact that the staff was making less mistakes in dosing the enoxaparin, which is the main treatment that is given for kidney function management. And we didn't even expect this. So there was apparently this reminder about checking the kidney functions of patients also resulted in closer following of the guidelines. And I would like to just use this example to make 2 points, which are that, this is in a way a very tech-driven project, one in which the patient perspective was not really important because unfortunately people in the ICU are not that involved in care, of course. But still the people factor ended up being the very decisive one, the one that in the end was the one the deciding factor on whether the system would deliver real-world results or not. And the second reflection that I would like to give this project is that in this case, we changed just a few things about the technology and the way the information flow was working, and still these had some unexpected effects on the way people behaved, which of course is just a confirmation of what we know about these 3 aspects being very closely interconnected to each other and having unpredicted effect on each other, sometimes negative and of course sometimes positive, as in this case. The second example that I would like to give very quickly is instead one about technology. So this is a case in which I think that it's a case that fascinates me a lot. It's not one that I've been involved in. But it's one in which I really think is an example in which the people factor was there, the information factor was there, but what was missing was the technology. So a few years ago, this movement called We Are Not Waiting started, which was basically a movement of diabetic patients who really wanted to implement something like closed loop glucose monitoring. And this means, having a glucose monitor that seamlessly sends data to then an insulin pump so that these two can go together and they don't need to manually administer insulin to themselves after having checked the glucose readings. And this is the concept of the closed loop. And the We Are Not Waiting hashtag gained prominence because essentially the point was that people didn't want to wait for someone to implement this technology. They wanted it immediately because they saw it was possible. They saw it was, just a matter of building it. And up until the point in which Dana Lewis, a diabetic patient, basically built the system for herself. She connected the information coming from her glucose monitor to her insulin pump. She basically learned to code to be able to do this and finally managed to do this closed loop. And of course, what she did is then to make this project available open source for everybody else. And now still the system, or at least a more updated system based on what she has developed, is now being very widely implemented and also tested in clinical trials. And I think this is a nice example of a situation in which here people were already involved and very eager. There was a lot of demand. The data was available because the glucose monitoring, of course, was already very, very common and easy to do. But there was this missing link of the technology that people wanted so much that in the end they did it themselves. So in this case, for instance, you could say that the technology was the factor that was missing. The last example is one in which perhaps I would need to convince you a bit more, because as designer, I think we were all already agreeing that both people and technology are important. But I would just like to make a case for also the importance of information. And this is the last point that I will make, the last example that I will give. So this is instead a project I have been working a few years ago about ambulance services. And one of the things that we immediately realized by doing user research in ambulance services is that information exchanges along the care path of emergency care are very scattered and very important at the same time, because basically the information flow goes like this. For someone calls the emergency center, at least in the Netherlands, again, for different healthcare system, there is either the patient or a bystander that calls the emergency center. This person then gets in touch with the ambulance crew that goes on the scene. Once the ambulance crew goes on the scene, they will also, of course, ask for information in whatever ways available, gather data, about what happened on the scene. And then if and when they bring the patient to the hospital, they will be the ones then telling what happened, making a summary of what they have, of what they know so far. And in turn, then the person that they will have given this description to will be the one talking to the doctor who will eventually make the diagnosis. So you can see it's really a stream of data with many, many players in the midst of this, and unfortunately many possibilities to make mistake in this information flow. One of these mistakes was this example that was given to me that has always struck with me, which is this case in which a customer was in a restaurant when they started to have breathing difficulties, and the ambulance nurse mistakenly thought that they could have been suffering from a heart attack. This is the way in which the ambulance nurse described the case to the hospital when they arrived, and the physician who visited this patient agreed, thought that it could be a right diagnosis. And instead, it was later found that this patient had choked on a piece of food instead of having had a heart attack. And unfortunately, this misdiagnosis, which you could say was directly a consequence of a mistake in the flow of information, resulted in the death of this patient. Also in ambulance care, what is very hard in terms of information is that of information collection is that paramedics are supposed to gather detailed information also in terms of vital signs while they are actively on an emergency scene. And that is, of course, cognitively and even just ergonomically extremely complicated, because they are doing something else in the moment in which they are responding to the emergency situation. But they also, on top of that, have to remember and take note of what's happening, because then they later have to report it by, as you can see in the picture, they basically can be back in the ambulance and fill in a complete report of what happened on the scene. And they need to do it ideally before they go on the next ride. But of course, also that is, you never know when the next ride will be. So it's emergency care. It's a context in which information flows are very important, but also very hard. And a lot is demanded out of staff in terms of information collection and delivery. This is why we really focused in this project on this aspect, and we try to map all of the channels, all of the information channels, and the points of of communication between different staff members and levels of care. And this is why in the end the concept that we came up with is this kind of earpiece that could be used by paramedics to just hands-free collect information. So paramedics could just speak, could just tell what they saw, and it could be recorded in the earpiece and pre-fill a report that they could later just review and correct if needed, but not have to write from scratch. And of course, also the earpiece could be used for hands-free communication with the hospital on the way, so that basically paramedics could just think about looking at the patient and having their hands free to do whatever they needed to, instead of having to fill information either on their gloves or on the laptop in the ambulance. And to conclude this, to make my point about the importance of information, one thing that I really believe is especially true in healthcare, perhaps differently from other design domains, is about the importance of information. There is this quote that I always like, which pinpoints how much in medicine is decided by the way information is processed, recorded, retrieved, and communicated. But then you could ask, okay, it could be convincing. It could be true that the people aspect, the information aspect, and the technology aspects are important. But if they're so intertwined, why even making a difference between these three aspects? Why are we even talking about the three as if they are separated when they are so interconnected? And I think it would be a fair question, but at least one answer that I could give is that we need to consider them also separately, because there are different disciplines that have to do with each of the three aspects. Different ways of working, which not necessarily are easy to reconcile with each other. And therefore, to do healthcare system design, one of our goals must be to reconcile the aspect of people, the aspect of information, and the aspect of technology. Because, of course, in the end, they all need to work together. I will just close by saying, in my research, and I don't, of course, suggest that this is the answer about how to reconcile these three aspects. But in my own research, one way in which I propose to go in this direction of this integration of different perspectives is what I call the convergent approaches to health systems design, which are particularly focusing on sharing data strategies between the data that is used for design processes and the data that is used for other kind of processes within healthcare innovation. And these other processes could be, for instance, of course, clinical evaluation or cost evaluation, and so on. What I'm interested in, especially in the e-health domain, is the way in which the data itself and the databases could be used for aligning different disciplines. For instance, in a recent study that we are working on with the Leiden University Medical Center, we really try to build a shared data strategy that we could use both for design purposes and for health research, for running the clinical trial. However, I will stop for now. I'm very happy for any questions, of course, about the presentation even separately. But for now, I would just like to go for a break. And when we are back, we will be able to work a bit more on this, first on the differences between people, information, and technology, and how to make this difference, and then on the integration of these different perspectives. But for now, we'll stop here, and let's see how much we can afford for a break.
Valeria, I think if we start at 40 again, so we take a 7-minute break, and then we do each activity for 10 minutes, then we are back on track, and then we have time enough for discussion. Would it be a good idea?
I agree, Alex. Do you?
Okay, then
perfect. In this
each
case,
other
in
at
6 minutes.
40, 6 minutes break. See you.
Thanks, everyone.
Hello, everybody. I think we can start. Valeria, maybe you can guide us to the Miro board, and maybe also share it here because, yeah, as I said, I have problems
Yes.
doing it.
Yes, that's
Do
a
you
good
want
idea.
breakout rooms, Valeria?
Oh, maybe first I will explain the workshop and then indeed breakout rooms would be nice. I will just... So we are in activity 2, part 1, and I think this is where there are different rooms, of course. The idea for this activity is just that we look at these kind of overlaps between the areas of people, information, and technology, and we look at the disciplines that we think are belonging to each. So I have pre-filled some that I think are relatively uncontroversial to put in each area, but maybe not. So what I would like you to do in the breakout rooms is just to write down disciplines that you think are for healthcare systems design afferent to these 3 different perspectives. And I would also please beg you to note where you have disagreements within your breakout rooms. So for instance, if someone says, I don't think psychology should be in that area, please also label that down in any ways, or even just remember about it, because I think that is going to be interesting to discuss later when we discuss the results. Yeah, I think I would suggest just going in the breakout rooms for 10 minutes, maybe even just a bit less to get back on time. But let me know if there is any doubt about how to go ahead with this activity for now.
Would you like to separate?
So I'll create three rooms.
Yeah, that would be great. I think so. And then probably automatically assigned.
All right. 3 rooms for 8 minutes.
Thanks. Will we be automatically sent to the rooms?
Yes, it'll be random allocation. Oh, okay. Create rooms. Breakouts have been created. You will be, should happen somehow. So you're going to explain the second part, then we go back again, right?
That's right. And then I would leave the discussion at the end.
Yeah.
I think I got thrown out of my room.
Yeah, that's right. It was a very quick one.
Yeah.
But we will be in the same breakout, Valeria.
For the second one?
Yeah.
I am not sure. No, I think it will be random, so it will be a different group.
I think it will be a different group. Maybe.
If people are confused, you have to remember to share your video and microphone again when you come back again.
Yes.
Yeah, that's not the best.
Welcome to Hopping.
Yeah, Hopping is not as easy as the name kind of.
The name was an indication.
I think if they called it hobbling, it probably wouldn't have sold.
Better. Are we only with 6 left now?
I see more people active on the Maier board, but hi Tina, welcome back.
Hi.
Video.
Now we have Maier
Got
back.
kicked off, so rude.
Okay, I think we're coming back now. It's coming home.
Hi everyone, welcome back. I think we're slowly getting people from the breakout rooms.
Very slow process.
I'm not sure if the ones who are yet to join can hear me, or if it's just a matter of their video and audio being missing.
Yeah, they should be able to hear you.
So maybe what do you think? I should already go through to the second activity instead of waiting for everyone to be able to share their screen, to share their video. I think I should go ahead. And then, of course, if there's anyone coming, we might be able to catch up. So thank you very much for going for this quick first activity. We are going to go for another quick one that is related. So the first one was about distinguishing, or an aspect of distinguishing these three perspectives. The second is a bit more about integrating these three perspectives. And here I have in Maier this sort of fictional scenario that you can see for the part 2, in which there is a project in which a service designer, a data scientist, and a biomedical engineer are disagreeing about what's the priority in the project. Let's say that this is a project about remote patient monitoring, in which you want to use monitoring data to predict adverse events. And then, for instance, it might be that the biomedical engineer, of course, is really focused on prioritizing, checking whether the sensors are accurate enough. The data scientist might be focused on checking whether the algorithm is predictive enough. And the service designer may want to check if people want the service in the first place, and if there's any need that this service is filling. But of course, the project manager is sort of sick of having to accommodate these different perspectives, and an agreement needs to be reached. So in this situation, what I would like to do, again divided in breakout rooms, is to try to decide on a strategy in this fictional situation for integrating the three perspectives. And if you have any time left, otherwise it's fine, try to think of what would be the first study that you organize for such a project. And again, we're going to be divided, and after this activity, we'll come back together to discuss both of them, both the previous and this one, and see what we came up with.
Yeah, Valeria.
How many minutes?
10 minutes, isn't it?
Yeah, that's right. Also
10 minutes?
Yeah.
Okay.
And I am
We'll
happy
get
to get
you going
people
in a
joining.
minute.
Thanks. Oh, by the way, I didn't say it in the other time, but the number of your breakout room should also be the number of the canvas that you stick your sticky notes on.
All right, so ready to go for 10 minutes.
Thanks, Alex.
No worries. You'll be off in a minute.
Hi, Alex and Valeria.
Welcome back.
Hi, John.
It's scary. We're mid-flight having a great conversation, and suddenly all I see is Alex filling my screen.
We got cut at a very interesting point.
You get
And then I spoil the conversation.
You get cut off those breakout sessions. So rude. It's like no, not in 10 seconds. You have to leave. No, it's like, and now you're gone. Oh, that's hard. But okay.
That's technology. We have no feelings,
No.
you see.
No empathic design, yeah.
As feedback to hopping. might ask Hopin if it can be a bit more polite.
I'll make sure to add that to our feedback to them after the conference.
Okay, shall we move to a general discussion where we just go quickly through the mirror board and then stop the discussion at 10, 4:20, 3:20 UK time, so that Anja has 10 minutes left to finish and kind of wrap up this workshop.
Thanks, Maaike. Indeed, I would maybe like to start with room 1. I see that at least one person from every room managed to join back the general call. So I wonder if either Maria, Jivon, or John would like to share just a few things about the first part of the activity, so putting disciplines in the 3 areas, and especially tell us if you disagreed on any of the placements. That would be the most interesting.
Well, we got to the disagreement part, and then we were moved back to the main room, so we didn't really disagree.
So you agreed on everything. Let me see what's in there. Public health, medicine, information design, data design. Interesting. Oh, there are different kinds of design. This was good for us. We just put design in the middle of everything, and we didn't touch it anymore. I guess we couldn't choose. Linguistics.
Maybe why we didn't disagree. We separated everything out, so we couldn't disagree.
You couldn't disagree.
Exactly.
I'm intrigued by linguistics being in people and not at all in information. But
Well, it's about
I won't be the
people.
one.
It's about common language, people expression. That's why I put it in more to people, less to do with information. But you're right, it could sit on the boundary.
I like that there are many things on the boundaries as well. Indeed, safety engineering, it's something that, right, or human factors engineering, it's something that is right at the middle between the technology part and the people part. I will, no offense, but then I will move already to the second one with Manish et al. Is Manish already back? Yes, I see him.
I'm here.
Yes,
Yeah.
Manish is here.
Yeah.
I
Manish,
think
would you like to
the
share
audio,
something?
yeah, I think we put in various pieces at various spot. We were wondering where to put politicians. Of course, that was something we were not able to decide. We did put information engineering at the borders because, of course, that's between technology and information. I think maybe people who are there could also comment on what was specific.
That makes sense.
Yeah.
To me.
I think there was a discussion on whether politics should be right in the middle or outside completely.
Yeah.
So we didn't quite. So we ran out of time, so they left them outside.
Yeah.
So
I guess
policy can affect everything.
So besides the politician we talked about, we kind of had a tough time really defining what information and technology and people really mean for us. And that was really hard because then it's kind of where to put the different nodes, because what is information, what is technology? Is technology only the product, or is technology also kind of the information, the data you gather, what you're doing with the data? So that was, I guess, the hugest struggle we had, or the challenging part for us.
Right. They're very entangled. Thanks. It's true. I think also that this is why I thought this was kind of a discussion starter, because I think distinguishing the 3 perspectives or agreeing altogether on distinguishing the 3 perspectives would be very hard. Moving on, room number 3. This was the one I was in, but I would like to ask if anybody else that was in there would have something to share. What I saw, we had a very small conversation about where to put medicine and nursing as disciplines. And then it was interesting because I think what we were thinking is that we would have put medicine more at the intersection between people and the information, and then nursing more on the people side. But that was a small nuance so that we were thinking about. Is there anybody else that was in this group who thought there could be something interesting here?
Anja, do you want to say something?
Oh, my microphone is on. Yes, sorry. I was just checking. Well, that's maybe also one of the summary sentences. I think it's that those interfaces that are important. It's not so much what belongs where. It's perhaps more how might we link the perspectives. I know this is a high level comment.
But
it makes sense.
I wanted to make a similar comment when the other group was splitting all the disciplines. And on one hand, it's good to be very precise, but it's also kind of shifting the problem, because the more disciplines we put around the diagram, the more interfaces we will have, and the more, we have to think about these interfaces. So I think it is interesting to see where the cuts should be and where to be precise and where to put things in a box to kind of avoid problems later.
I agree, and also think this is a perfect way to pass to discussing the second exercise. Well, at least because in our room, again, this came out as an interesting topic. But first, I would like, I don't know anymore who was in each room, but I see that room number 1 has quite a bit of post-its, and also already some an idea for a first study to conduct in the project. So if anyone from that room would like to come up and summarize the results, that would be great.
Sorry, that's us, isn't it?
Yes, that's us.
One. I'm just gonna move my Miro view down. Yeah, I think that when we were talking about our strategy, it seemed like it kind of specified or fed in very well to what we imagined a first study could be. When we thought about what would be needed in order to integrate all these perspectives, that we would start with an analysis of stakeholder needs. So it would be clear that not only the people involved here, but also the different people involved in the solution, and that we'd need to think about what their individual and shared needs and goals would be for the project. But that would also involve looking at the context. So where is it being implemented and the possible scenarios, what it would mean to integrate continuous monitoring, because I'm assuming that would be different from what was there before. And of course, it would need to be important to look at how monitoring was carried out previously, and how we would be able to actually work within that potential workflow or that sort of state, and sort of work with the different people who were normally doing a different process during that time. And then how we would outline each of the stakeholders' capabilities and contributions to the project, and how we could help them communicate in that process. And that we would need to make sure we clarified some clear touch points and goals along the way, because those would be different for each of the people working in the project. We talked about the double diamond, and the first study would probably be a workshop, possibly using the double diamond, but to identify the sort of individual needs and the shared needs and goals in the project and the best outcomes.
Thank you, Alex. So this sounds like brilliant project management and also like a very good summary. Can I just ask, for curiosity, how about the role of the double diamond in this aligning?
And I might actually reflect that onto Alexander, because Alex had kind of suggested that when he was over in our room.
Yeah, so I was just hopping around the breakout room, and I think the idea is the divergence and convergence in thinking, really, in terms of the nature of the problem require that open-minded exploration, the need, and all of that context to understand what's going on before narrowing down into what we think is the problem to solve. So I think that's why the double diamond was quite sounded appropriate, but it was just meant to be a suggestion to the team.
Thank you. That makes a lot of sense for me, and also it explains. For me, at least, it makes me think back about the basics of design methodology. I would move also in the interest of time to room number 2. I need to say we had a bit of more of a perhaps abstract discussion in our room. But again, maybe I would step back and leave Anja, Maaike, or Jiwon to talk a little bit about it. We have just a few post-its actually, and we didn't go to the second part. But I still thought it was an interesting discussion.
Possibly Jiwon, if you're here, would you care
Yeah,
to?
I was thinking, Jiwon, can you take the
If you
floor?
click the blue button on the top right.
I thought that she just joined back.
Yeah, I just asked for the permission. Okay, so we talk about the hierarchy, the different hierarchy between the disciplines. So we started from Korea. I don't know other countries, but particularly in my country, we have a different hierarchy between discipline. Like healthcare is the high, like clinicians, they are usually highest, and then technology is below, next to, and then the lowest hierarchy is usually about the people. And then we had the discussion about, is it better to flat those hierarchy, or is it better to just play with those hierarchy and then make those hierarchy to work the what we intended to make change to proceed. And I think based on our conclusion, in order to collaborate and to resolve the conflict, I think we need to play with those hierarchy, and then somehow we let the one who are in the highest hierarchy push to make change. I think that was our conclusion of discussion mainly.
Yeah,
Thanks, Jiwon.
Shall we move
Maaike.
to the last?
Yes, to the last one. And I would like to ask either Tina, Manish, or John to tell us what happened in that room.
Yeah, so maybe I just reflect what we're talking about. So we kind of skipped the first task. So we weren't really talking about the strategy for integrating the 3 perspectives. We kind of, our discussion flowed in the direction of the study and what would be the most important for us to identify at the beginning. And we didn't really talk about the study design, but that for us, it was most important that we identify the user needs, but not only what they are telling us, what is important for them. So also why those needs are important for them, and so that we kind of transfer to a prioritization, so that we get just a more holistic view of what they really want and what they really need and why they need it. And so to make the monitoring or the remote patient monitoring the best for the expected users. And what we thought about and discussed very largely was that it's not only about the user needs of the user themselves, but also about all the different stakeholders, and that it kind of a huge challenge for the study to identify them in the first place. So it shouldn't be only about us, the user, but also maybe third persons or third parties or doctors, practitioners, whatever. Also the context in which they kind of have the interaction with the product. And what we also said was important, maybe also before the real study can be conducted, is that we really need to know what the problem, what is the problem we try to solve. And for us, it was very important to get different perspectives, just to get to the core of the problem. Yeah, I guess that sums up what we are talking about.
Thank you. I'm taking over now from Valeria. She had an emergency, so she had to go. But I think this is a nice roundup of the second activity, and that brings us to the finalization of the workshop. I think despite the fact that we had not so many participants, I think we had very lively and fruitful discussions with different angles from different nationalities and schools. So Anja, the floor is yours to summarize some of it. And to finalize this workshop. Thanks.
Great. Yes, thank you, Maaike. So I'll start with chronologically how we went through, and then have some reflections after each part and some actions we might do. So firstly, with the first presentation on the different perspectives of national healthcare systems, I thought that started out very thoughtfully, really with that question, what does health include? And that's a very strong and deep question, because if we think about it, as a consequence, that also says, where does the responsibility lie and who does what? And for us as designers, for example, if we say, well, we're looking at who's diagnosed how, that means, are we then designing to specification of that diagnosis? Or is the person actually not necessarily the diagnosis, right? So I thought it was very, very thoughtfully put and gives us a lot of actions. Where do we center as designers? Is it really that diagnosis, or is it actually the environment around it, the prevention, the preparation? And then very specifically, the discussions on the different national systems, 10 in total we had, and multiple perspectives on some countries also. Again, very, very strong in terms of 2 points stand out for me there. Is it the data infrastructure or the regulatory infrastructure that drives our designerly behavior? Or is it actually, could we look at the people again in the center, irrespective of that regulatory and infrastructure around it? Quite a few thoughts again came, and again, maybe I'm just homing in on a similar point from different directions, but for me, what came out was, again, is it health or is it care? So is it awareness about your health? Is it the human, or is it care? Is it you as a patient, where you're already diagnosed? Again, I think that is really, for us as designers, is a good call to action to question our assumptions underneath, or rather what the people are telling us where the issues lie. So very, very interesting all in all, that first part. And what we will now do is take that into a collaborative chapter and really reflect on some of these aspects. In what way does that influence the way we design? So that's one part. And I also encourage all of you to keep holding that conversations together. Maybe we have individual co-authorships or projects across countries. We saw a lot of examples. This comes also a bit in the next part. For example, on remote patient monitoring. Again, can we maybe connect different countries on that and the repeat studies? Now for the second part, again kicked off by a very interesting presentation with clear examples on, well, examples on people, examples on technology, on information. At the same time, these clear examples in the end were perhaps not so clear in terms of, is it really so separable? But that was the whole exercise, to say in the end, it's again about the balance. How do we link up to make technology work for humans and have an enabling infrastructure around it? Here, I'd like to share, there's a movement happening. It's called openhumans.org. And that's quite interesting, because that blurs the boundary again between patients and citizens. It's not relying on national countries to log all the data. It's actually individuals who then are engaged with their health through their data. Here again, I think call to action for us designing interfaces is what we need to do as designers, at least I'm convinced. And again, here we will translate some of the work in a collaborative book chapter. And now overall, from those thoughts, overall, Valeria mentioned it at the start, we would very much like to continue both in the design society organizational structure as well as bring the society out or make it wider. We will have another health systems design research international meeting, most likely in the autumn, most likely in France, to be discussed, hopefully in person, and also Delft, at Delft. So please watch that space, join us on LinkedIn, watch or monitor the Design Society website, which is open. You don't need to be a member to monitor that. Yeah, so those are the very concrete activities that we do. That's following. Now, of course, such a day was heavily prepared, and I would very much like to thank a number of people on behalf of the special interest group, but also us as individuals. So first and foremost, Dr. Alexander Kamashi, coordinating, shepherding, and also Dr. Valeria Panunzio for, again, also aligning the various parts. Of course, the chairs, Professor Maaike Kleinsmann also directing us through the day. And then, of course, everyone here with the lively discussion. And as a good combination between individual and thoughtful work, as well as then the open discussion. That was very fruitful. I think, hopefully I won't be too advancing in saying we will share the Miro board. Is that right, Alex? The results with participants are
yes, I think we will do that. I think Valeria would show us how to get the outputs out and make it available. But.
Yes. So yes, definitely. Again, on behalf of also all co-directors of the Health Systems Design SIG, Professor Clarkson, Professor Kleinsmann, and myself, thank you to all in your various roles. And we hope we can continue the conversation together. Now, very specifically, we also wish you a very, very good conference in going forward. Link up to the sessions. There are a number of health sessions, papers discussing various points in more detail. So please do join. And at 16:30, I have it now on my screen popping up, we have OnShape. We as the design organization, the conference, OnShape as the sponsor. And I think we all have gone through our education using some of their products. And again, having spoken so much about data and digitalization and how that shapes processes, it might actually be quite interesting to join them now, how they see the development in design engineering as a whole. Thank you, everyone, and hope to see you again at another workshop, at another session, maybe in a project funded through external organizations, possibly. That would be very, very nice. Or doctoral exchanges and so on and so forth. So thank you for today.
Thank you, Anja.
And I'll hand back to Alexander as human being, not a patient.
Well, I think you said it all. So it's nothing for me to say. Thank you, everybody, for lovely workshop.
And of course, the organization at the conference and the structure, Maier and so on. So, I mean, it's enabled through you that we, as an international community, come together. So also here, thank you.
Thank you.
Okay. Then
see you around in the conference.
Yes.
Somewhere.
See you later. Bye-bye.
Bye for now.
Thank you, Maaike, for sharing. Thank you.